So I am super excited to chat with today's guest. We have Dr. Jenn Simmons. We are going to be discussing breast cancer. It's going to be a fascinating topic. So let me go ahead and dive into Dr. Jenn's impressive bio here. So Dr. Jenn Simmons started her professional career as Philadelphia's first fellowship trained breast surgeon and spent 17 years as Philadelphia's top breast surgeon. Her own illness led to her discover functional medicine, and so enamored with the concept of creating health rather than killing disease, she left traditional medicine in 2019 and founded Real Health MD to help women along their breast cancer journey truly heal. So, Dr. Jenn is on a mission to change the impact of breast cancer by empowering millions of women to take control of their health and create the life they want. She hosts her weekly podcast, Keeping Abreast with Dr. Jenn, hosted the Breast Cancer Breakthrough Summit, is the author of The Smart Woman's Guide to Breast Cancer and Recipes for Real Health. Dr. Jenn is currently opening perfeQTion imaging centers across the country featuring QT imaging, an innovative technology that uses sound waves to create a 3D reconstruction of the breast without pain, compression, or radiation. This fast, affordable, FDA approved technology has 40 times the resolution of MRI and will forever change the way that we screen for breast cancer. Definitely need to talk about that while we chat. So, welcome,
I
Dr.
actually think
Jenn.
I can go home now. I think that we've covered it.
There we go. Yeah, we definitely got most of
This
your
is
background.
easy.
So we don't need to have you talk too much about your background because I think we pretty much unveiled everything. But I mean, I guess the one thing that while reading the bio, you said now you switched to functional medicine. It was in 2019 is when you started practicing more functional
Yeah,
medicine. So I guess what led to that transition to
yeah.
where you are today?
First, thank you so much for having me on. It's a pleasure to be here, and I've been really looking forward to this discussion. Um, I'm like everyone else. I have a pain to purpose story. And it was a very unpredicted pain to purpose story because when I was growing up, I really don't remember a time where I didn't know about breast cancer. It was really, truly the thread, the fabric, the tapestry of my family. And when I was a young child, I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She wrote all the music for the Spinners and the Stylistics. I'm really going to age myself now. She was beautiful, brilliant, larger than life, was the queen of Motown sound in Philadelphia, and she was my hero. She wrote 54 hits in all, and her most famous song was The Greatest Love of All. So she wrote that song in 1977 as the title track to the movie The Greatest, starring Muhammad Ali, but it really received its acclaim in March of 1986 when Whitney Houston would release that song to the world. And at that time, it would spend 14 weeks at the top of the charts. Only my cousin Linda would never know. Because Linda died of metastatic breast cancer just 1 month after Whitney released that song. I was 16 years old when my hero died, and her life, and ultimately her death, gave birth to my life's purpose. And I really thought that what I took from that was going to be my destiny. And because breast cancer was so prevalent in my family, because literally all the women in my family got breast cancer, I went into this field because I never wanted another woman, another family, another community to have to suffer the way that mine suffered. But I also went in thinking that this was inevitable for me, and I wanted to try to figure it out. So I became a doctor, became a surgeon. I became the first fellowship trained breast surgeon in Philadelphia. And I did that really well and for a really long time. And I did it long enough for my aunt to be diagnosed and my mother to be diagnosed. And about 10 years before my aunt was diagnosed, she developed Graves' disease. And I was far enough into my career at that point, and then when she subsequently developed breast cancer, to at least say, like, I wonder if there's something there. And I'm about 15 years into my career, arguably at the top of my game. I'm running the breast program for my hospital. I'm running the cancer program for my hospital. And I'm a wife and a mother and a stepmother and an athlete and a philanthropist. And I have all these balls in the air. And I fancy myself an expert juggler until the day where it all came crashing down for me. And I went from probably being one of the most high functioning people you've ever met to I couldn't walk across the room because I didn't have the breath in my body. And I spent 3 days with a really intensive workup because, when your prize pony is hurt, you figure out what's wrong fast. And I find myself sitting 3 days later in the office of my friend and colleague and physician. And he tells me that I have Graves' disease and that I need surgery and chemoradiation. And I'm going to be on lifelong hormone replacement. And though I knew that this was the standard of care, and though I knew that what he was telling me was what he knew to be true, it's what I knew to be true, something inside me said, no, there's more. There's something more. Go find it. I walked out of the office that day. He told me I was going to die. And it's not that I didn't believe him, but that there was just this very loud voice compelling me to look further, to search for options, to investigate, to look beyond what we are so trained in conventional medicine to see. Because the truth is that people think of doctors as critical thinkers, and I'm not exactly saying that they're not, but that even if you were before you went to medical school, once you get there, critical thought is not rewarded. The critical thinkers, once you're inside of the system, they're the quacks. They're dangerous. They're all the things, all the names that people call, that all the titles, the labels that we put on things that we don't know, we don't understand, and we fear. And I very much had blinders on. Even when I walked out of the office that day, I had no idea what I was walking into. So I was very fortunate to land very early in a space where I'm sitting in a lecture hall and a man walks on the stage, smiles his big toothy grin, and introduces himself as a functional medicine physician. Now, at this point, I'm a doctor for 20 years, conventionally trained at one of the best medical schools in the country. And all I could think of was, there's no such thing as a functional medicine doctor. So what is this quack talking about, right? I'm still in that place. I'm still in that mindset. And then I remember that I'm sick and I'm there for a reason. And I check my ego at the door and I tune in, and thank God I did. Because the man was Mark Hyman. And though he is very famous, in 2017, maybe not so much. And I had no idea who he was. But what he had to say over the next 2 hours would move me more than anything had before, and maybe since. He would actually foretell not only what was going to happen to me, but what was going to happen to the rest of my career, what my goals were, what my aspirations were. And granted, I'm an early adopter, but I left that day and enrolled in the Institute for Functional Medicine because I too wanted to practice root cause medicine. I too wanted to understand where disease was coming from rather than managing symptoms. I wanted to heal for sure. And, a large part of the initial part of this journey was about me. But once I engrossed myself in the study of functional medicine, there's really no looking back. I mean, that's a bell you can't unring. And I knew that I couldn't stay and practice within the confines of conventional medicine because when I was there, I was part of the problem. I wasn't part of the solution. And when you are helping anyone through any chronic disease, I mean, I happen to be talking about cancer, but we could almost talk about any chronic disease this way. If all you do is manage the symptom, and as a surgeon, all I was doing was managing the tumor. I was not in any way affecting the rest of their lives. I was maybe delaying a recurrence or I was delaying the next manifestation, but I wasn't doing anything to remove that inflammatory nidus that led to their disease. I wasn't in any way intervening in the process that got them there in the first place. And so I decided that where my place was in this world was to help millions of people recover from their disease, restore them to health, and maybe, just maybe, even lead them to the health that they never had their whole life. And that became my goal. And when I left clinical medicine, well, I'm still in clinical medicine, but let's say when I left surgery, of course, my colleagues thought I was crazy or I lost my skills or my mind or maybe all of them. I don't know. And it's funny because, it's about 5 years since I left and I went from the quack to, well, I know you're doing this, but if I were you, I would also go see Jenn Simmons. So, I know I have arrived when the people at Penn are now telling their people to come see me too. So, it's been a journey, and I don't want to paint too rosy a picture in that my healing journey was not linear and it was not easy. And I got a lot worse before I got better. But I am delighted to say that I did get better and that I am healthier now than I ever was my entire life. And it really wasn't until I got sick that I actually knew what it was to be well.
All right. Well, thank you so much for sharing that. It's great that you were able to save your thyroid, avoid the radioactive iodine, avoid the surgery, and keep that open mind that I try to encourage people listening to this who have hyperthyroidism, Graves' disease to have, as well as Hashimoto's, because as you know, with Hashimoto's, it's different
Yeah.
than Graves, but pretty much most endocrinologists will just recommend thyroid hormone replacement, and pretty much that's it. They won't do anything for the underlying cause. And
They
like
will.
you said, you could apply, as you mentioned, pretty much not everything, but a lot of what you're going to be discussing to other chronic health conditions. But yeah, obviously, let's dive more into breast cancer. As far as, can you talk a little bit more about like maybe the physiology of breast cancer, like how, like there's different types of breast cancer, right? Like not all breast cancers are estrogen dependent, and
Yeah.
just yeah.
And I don't even like that estrogen dependent word. But so first, it is, yes, a very heterogeneous disease, right? And what makes it so heterogeneous is think about what brings people to that diagnosis, because for everyone, it's going to be different. And so, though we can look at the cells under the microscope and say, oh, this is breast cancer, and maybe this one has estrogen receptors on it, and this one has progesterone receptors on it, and this one has HER2 receptors on it. And some have all of them and some have none of them. I mean, we can say all of that with uniformity, but the thing that's not uniform is what got you in that place in the first place. Because breast cancer is a normal response to an abnormal environment. And it's what is creating that environmental shift for people that leads to the disease state. So we know if we sample the environment, the microenvironment around a tumor, it chemically looks different. And what happens is that as we are exposed to any number of things in our environment, and these can be tangible things, they can be intangible things, they can be visible things, they can be invisible things. So stress, over-exercise, under-exercise, sleep deprivation, poor diet, chemicals, herbicides, fungicides, pesticides, pharmaceuticals, antibiotics, plastics, xenoestrogens, like you name it, we are exposed to thousands and thousands of chemicals every single day in one way or another that have this effect on our cells. And we all have an allopathic load that we're going to be able to tolerate, a toxic load that we're going to be able to tolerate. And once we all exceed our ability to tolerate that, whether it's stress that put us over the edge, whether it's a viral illness that put us over the edge, parasites, chronic metals, dental infections, like it doesn't matter what it is. When you reach your threshold, your body can no longer maintain that healthy environment. And so our cells perceive that. And things like the thyroid, things like the breast, they are our canaries in the coal mine. And so even minute environmental shifts, these are recognized as threatening to our cells. And so what do our cells do? They go into survival mode. Just turn it out. Just reproduce. Doesn't matter if you make a mistake. All we have to do is survive. That's what's happening. Now, that alone won't lead to cancer because we do have an immune system that is supposed to recognize these rogue cells, these cancer cells, these cells that have gone into this survival mode. You're supposed to recognize them in their infancy and destroy them before they can get mass, before they can form a tumor, before they can create a blood supply. But the problem is that our immune systems are working overtime and have been working overtime for way too long. And you can't fight it at all fronts. So, if you have a war going on, you can maybe be a really good soldier for a little while. But after a while, your army is just going to get exhausted. And that's what happens. And it's where those roads meet, where you've exceeded your toxic load, you're having this environmental shift from the chemistry of what I call joy to the chemistry of stress. You're getting DNA damage, and your immune system has been working overtime for so long that it just doesn't recognize it, goes unrecognized. And then it just grows from there. So, whether that is an invasive ductal carcinoma, an invasive lobular carcinoma, hormone positive, hormone negative, HER2 positive, these are all silos that were created for the purposes of prescribing the thing, the pill, the chemo, the whatever. Cancer is not a chemotherapy deficiency. It's not a radiation deficiency. It's not a surgery deficiency. Cancer is this normal response to this abnormal environment. And the key to all of it is figuring out where is that environmental shift coming from and helping to alleviate it. What do you have that you don't need? What do you need that you don't have? And how can we shift you back from the chemistry of stress to the chemistry of joy? And so, I don't disparage people who want to undergo conventional therapy. I get it. You're scared. And this is what everyone is telling you to do. And we all make the best decisions we can with the information that we have at the time. However, what I write about in my book and what I talk about all the time is that the very best thing that you can do if you get a diagnosis of any kind, unless it is actually emergency, not it just feeling like an emergency, but actually an emergency, is take a pause and think about, is there a message here? What is my body trying to tell me? And can you work on that for a little bit? Because for most women, breast cancer has been in the making for years. 3, 4, 5, 10 years. So you're taking a month, 2 months, 6 months to figure out where this is coming from, what is driving this, and can I turn this around? That's some really valuable information that if you can arrive at that, and I'm not saying you won't need the conventional therapies because, if you have a lot of tumor burden and your proverbial sink is overflowing, you need to mop up the floor. That's what surgery is. That's what chemotherapy is. That's what radiation is. And there are times when I use those things. I mean, if someone has a bone metastasis that's causing a fracture, I send them for radiation because we have a situation that needs to be dealt with right now. And I'm not going to solve the issue of what got you to cancer fast enough to relieve you of the pain. Because it's very, very hard to heal when you're in pain. Very hard to heal. And that's one of the major questions that I ask people. Where's your pain coming from? Where's your emotional pain coming from? Because we need to heal that. That's a lot of where breast cancer comes from. It comes from prolonged suffering. Your heart is hurting. Your brain is hurting. Your body is hurting. And so for me, the functional medicine part of it, the why is this happening, the root cause part of it, that's the end. That's the always. These are the questions that we need to be asking every single person whose body isn't functioning optimally. Because unlike conventional medicine, where inside of conventional medicine, we think of health as the absence of disease, right? Like if you don't need to go to the doctor because you're not broken, then you're healthy. Instead, what we need to think about is that health is optimal function. And if you're not functioning optimally, you ought to be working on doing that. And this should be all of our pursuits, is to function optimally and live as long as possible and die young.
Yeah, definitely agree with that. And uh, as you mentioned, I mean, overlap between thyroid autoimmunity. You mentioned the thyroid and the breast kind of being the canaries in the coal mine. And so, really the same thing. I look at Graves and Hashimoto as more of an immune system condition. And not to say there's not a time and place for conventional medicine, whether it's anti-thyroid medication to help lower the thyroid hormones, and in some cases, thyroid surgery. But either way, you want to do things to address the cause of the problem, the stressors, the traumas, the toxins, the infections. Again, so I'm
It's an
glad you.
and, right? It's an
Yep,
and. And there is nothing wrong with taking thyroid hormone replacement, right? Like, I don't want to say for a moment that there's anything shameful about doing that, right? If you need it,
agreed.
you need it. But at the same time, you should be asking yourself, like, where are my thyroid antibodies? What's driving that? What do I need to do? How do I need to change? What do I need that I'm not getting that is continuing, that my body continues to be in this state, right? But as you well know, most doctors aren't even checking those antibodies. They're not following those antibodies. They're not thinking, what is actively happening with my patient? I mean, most doctors that I see aren't even measuring full thyroid panels. They're getting a TSH and treating that. And, you can have a TSH in the normal range, although right now we have a range that, 95% of people will fall into that we call normal. And we know that 95% of us are not metabolically healthy. And the thyroid gland and thyroid hormone is the center of metabolic health. So when we use something like TSH to guide our therapy and to determine who's well and who's not, we're doing people a great disservice. And the most important factor in all of that, in all of thyroid disease, as far as I'm concerned, is look at the person in front of you and ask them how they're feeling. They'll tell you, right? You can put a lot of people on Synthroid. They don't feel any better. And if they don't feel any better and all you are doing is treating that TSH, you're not helping that person in front of you at all. And we need a lot more thyroid literate physicians, providers. I don't mean to say physicians because I think there's lots of providers out there who are doing really good work and they don't necessarily have an MD or a DO or whatever behind their name, but that we need a lot more thyroid literate practitioners. We really do. I think the last statistic that I saw was, 1 in 4 people have thyroid disease. This is an epidemic. And we need to start to address it properly because otherwise we're really suffering as a society and we're suffering unnecessarily.
Yeah, I agree. Speaking of statistics, do you know what the statistics are with regards to breast cancer? Like what percentage of women will go on? And I mean, some men also develop breast cancer. So I guess overall.
So 1 in 1,000 breast cancer cases are men. And the statistics for breast cancer for the vast majority of my career were that somewhere between 1 in 7 and 1 in 8 women over the lifetime would get breast cancer. Those numbers are changing. And now we have a 1 in 3 lifetime risk of cancer, and it's only going to get worse because of a little epidemic that the world experienced a few years ago. And we're starting to see the data come out of that. But I'll tell you that before 2021, it was an absolute rarity to see breast cancer in someone in her 20s. Not so much anymore. I don't want to say too much on that because I don't want to take away from the focus of this discussion, and I don't want to get it flagged and thrown out anywhere. But we're going to be seeing a lot more information about how we're going to have worsening cancer statistics, younger, more prevalent, unfortunately. Yeah.
Yeah, that's interesting. I mean, I would think also just our toxic environments and the xenoestrogens. Again, not to blame everything on estrogen, but there is a difference between, and we'll get into. I mean, we could talk about this conversation now because I understand why you don't like the term estrogen dependent because again, it doesn't. It's everything else that's setting the stage, but the
Well,
xenoestrogens, don't they play a big role in not only?
absolutely
Yeah,
100%. But what we have to remember is that estrogen is the hormone of life. And it's actually when we lose our estrogen that we start to die. And when you look at what happens with cardiovascular health after menopause, what happens with brain health, skin health, bone health, joint health, gut health, vaginal health, bladder health, like literally everything we lose after menopause. And that's because estrogen is the hormone of life. Estrogen does not cause breast cancer. If you believe that estrogen causes breast cancer, you have to believe that women were put on this earth for the purposes of getting breast cancer. It's ridiculous. If you believe that estrogen causes breast cancer, then how do you explain the fact that the vast majority of breast cancers happen in the postmenopausal woman, not in the premenopausal woman? If you believe that estrogen causes breast cancer, how do you explain the fact that women who are pregnant have 10 times the amount of circulating estrogen, and breast cancer during pregnancy is relatively rare? Estrogen does not cause breast cancer. That said, there are a number of compounds in our environment that mimic estrogen, that sit on the estrogen receptor and abnormally stimulate it, and have to be detoxified down the pathways that estrogen uses. And the metabolites, the byproducts of that breakdown, are very toxic. And there is no question that these xenoestrogens, that these metalloestrogens are leading to an increase in breast cancer, because they're leading to an increase in DNA damage. They're leading to an increase in gynecologic cancers. It's not only breast cancer that is suffering as a result of this toxic soup that we're all swimming in. So, we're talking about things like plastics and antibiotics and antibacterials, antifungals, metalloestrogens, the things that we used for metallic fillings for years and years and years are 50% mercury, some even more. So, all of these things that we barely think about in the course of our day. You get up in the morning and you make your cup of coffee with your Keurig, and you're basically pouring hot water through a plastic cup and drinking it. And if you're doing that and drinking out of plastic bottles and cooking in nonstick pans, and you eat a fair amount of seafood, you're basically like eating a credit card every week. Would you voluntarily eat a credit card every week?
Definitely not.
Definitely not, right? But these are the invisible toxins that we don't think about because we don't see them. And they're having profoundly negative effects on our health. Now, the place where the hormone-driven cancer came from is, there are narratives created for many purposes. A lot of times we create narratives to sell pharmaceuticals, to make the story easier to understand, to make it seem logical and acceptable. And this is one of those instances. So, do the majority of breast cancers have estrogen and progesterone receptors on them? Yes, they do. Do breast cancer cells, normal breast cancer cells, have estrogen and progesterone receptors on them? Yes, they do. That's how they listen to cell signaling. That's how they do what they're supposed to do. And when you have a breast cancer that has estrogen and progesterone receptors on it, it means that it's not too far a departure from normal. It's trying to maintain those normal signaling methods. Now, we do have an upregulation, meaning that we make more, and usually we make more because there's not enough estrogen or progesterone out there. And so your cell is just looking to survive. It's just trying to figure out how can I get back? How can I keep up? It's the tumor cells that don't have estrogen and progesterone receptors on them that have really mutated from normal. And they are no longer following these hormonal signals, these normal pathways. They've really gone rogue. So to me, I don't think that we should be thinking about hormone positivity like that. And after all, I mean, in a premenopausal woman with a hormone-positive cancer, what is being recommended? Tamoxifen. Tamoxifen is a form of estrogen. We don't talk about that, but that's what it is. It's a form of estrogen sitting on the estrogen receptor. And like estrogen, it's protective in the breast, not so much in the uterus. In the uterus, we have a problem with tamoxifen. And that's why women on tamoxifen have an increased risk of uterine cancer, because it's not protective in the uterus. It's stimulatory in the uterus. So I don't think that the whole story is being told to people, and they're not given the ability to understand the whole truth in a way that they can truly make informed decisions. And that's another reason why I wrote my book, The Smart Woman's Guide to Breast Cancer, because I wanted people to be able to understand, what is breast cancer? What do all these things mean? How do I read my pathology report? How does this make sense to me? And then, what are these treatments that you're proposing? What do they actually do? Do they actually benefit me? What is that benefit going to be for me? And what else can I do? What can I do to actually take control of my health? And what can I do to reverse this or make it better? And so when people know the real numbers and have the real information, they make very different decisions.
Yeah, definitely agree with what you said. And thank you for that explanation. I want to switch gears and talk about screening, because I know that you're not a big fan of mammograms. I'm not a big fan of mammograms either. So I'd like you to talk about mammograms,
Yeah.
thermography, whatever you're willing to talk
Yeah,
about.
absolutely. I don't know if there are a lot of people left other than the manufacturers that are continue to be big fans of mammograms, right? It's a miserable, miserable procedure. Anyone who's had one will attest to it. But women in general do what they're told as long as it's for the good. And we will sustain a lot of pain, a lot of discomfort, a lot of anguish if we know it's for the good. If we didn't, the population would be over, because no one would voluntarily go through childbirth. But mammograms, we've been told for 50 years, save lives. And so women dutifully go and get their mammogram every single year. And it's a lovely, lovely theory. It just doesn't happen to be true. And we've known this for a very, very long time. The mammographic screening program started out in the early 1970s, and it started out built on this premise, this understanding, this belief that breast cancer growth is both linear and predictable. So if you found a breast cancer small before it reached to this critical size, at which time it would be more likely to metastasize, that we could save lives and save breaths. And it's a lovely theory. But breast cancer growth is neither linear nor predictable. And a cancer is what it is, a breast cancer is what it is from the very beginning. So if it's going to be an aggressive breast cancer, it's an aggressive breast cancer from the very start. And it doesn't matter how early you find it, this person is going to have a difficult battle with this disease. And there are breast cancers that are very unaggressive, and it almost doesn't matter what you do, these people do fine, and everything in between. And by 1978, we knew that there was no survival advantage to screening with mammogram. We knew that. And yet, we continued to do it. And we continue to do it today. And as a result, we cause thousands of breast cancers every year from the radiation, thousands. And we treat thousands of women for breast cancer that never needed to be treated. because no matter how many mammograms we do every year, the same exact number of women die of breast cancer every year, the same exact number. We are not impacting the bottom line. No matter how many mammograms we do every year, we have the same exact number of women who present with aggressive disease. And we know from the Swedish studies where they looked at two populations of women. They looked at women who screened for breast cancer and women who didn't screen for breast cancer. And the thing is, both of these populations had equal access to care and access to equal care, in that they both had access to good care. And when we look at the two groups, there is no difference in survival from breast cancer. The difference is incidence, because they treated a lot more women for breast cancer in the screening group than in the group that didn't screen. So we have known for decades that screening with mammogram doesn't save lives. But how about if it doesn't save lives, how about if it saves breasts? Because that's important, right? If it saves breasts, that may be a reason enough to do it. Unfortunately, as it turns out, if you give a woman a diagnosis of breast cancer, that's all she hears. And many, many women will opt for mastectomy, not because they need it, but because they're afraid. Because we know, statistically speaking, there is no survival advantage to doing mastectomy over lumpectomy. None. None. And yet, we're not saving breasts, because women are so terrified of dying that they somehow think that if they remove their breast, they'll have a lower chance of dying. But the statistics do not support that at all. So we're not saving lives, and we're not saving breasts. And like Switzerland, it is time to abandon our mammographic screening program. We are not helping women, we are hurting women. And we're hurting them to the tune of hundreds of thousands. It's not insignificant. And the women that are getting overdiagnosed and overtreated are shortening their lives and diminishing the quality of their lives. Because if you are treated for a breast cancer that didn't need to be treated, the 40,000 women a year with DCIS, with non-invasive disease, I hesitate to even call it breast cancer. DCIS stands for ductal carcinoma in situ. These women would never have died of their disease, never. And then we treat them like they have breast cancer. And the treatments for breast cancer are not benign. Those scars from mastectomy run deep, and lots of women with DCIS end up with mastectomy. The anti-hormonal treatments that are given to address DCIS for prevention, these lead to the acceleration of heart disease. They decrease mental capacity, decrease cognition, interfere with sleep. These are all really important things. They accelerate bone loss. They cause pain, discomfort, depression, anxiety. I mean, these are really serious things that lead to premature death. And a woman treated for breast cancer is 2 to 3 times more likely to die of cardiac disease than someone who isn't. We are not helping these women. We are hurting them, and hurting them to the tune of hundreds of thousands every single year. It's unacceptable. It's really unacceptable. Now, I never like to present a problem without offering a solution. So I'm going to say that, women in general don't want to sit by idle. They want to do something. And I am a huge believer in self-breast examination. I think that everyone should know what their breasts feel like, what their breasts look like, so that if there's a change, you're able to recognize that change and intervene. And if you're going to have a breast cancer that is clinically relevant, you're going to be able to detect that lesion before it is before it is meaningful, unless it's an aggressive cancer. And if it's an aggressive cancer, screening with mammogram wouldn't have helped you anyway. So I fully believe in self-breast examination. However, there are a lot of people that want to do more. You mentioned thermography. I love thermography as a tool to find inflammation, to screen for inflammation, because that's what it is. It gives off a heat signal and shows us areas of the body that are inflamed. What it is not is a screening tool for breast cancer. And that's where thermography got a bad rap. So I use thermography very frequently in my practice to look for inflammation, but I do not use it as a screening tool for cancer. If you're going to use it as a screening tool for cancer, it has to be paired with another modality like ultrasound. And it should be done by someone who does both so that they can interpret these images and correlate these images in real time. So that's one way to go. Is ultrasound a sensitive modality? No. It's sensitive enough, but will it miss a lot? Yes. Is it operator dependent? Yes. Is it the perfect screening tool? Not by a mile. But it is one screening tool. MRI for a while was thought to be the great hope for screening, especially in dense breasted women or high risk women or that kind of thing. But the problems with MRI are many. First of all, it's time consuming, it's expensive, it's uncomfortable. But the biggest problem with MRI, from my perspective, is that it uses gadolinium. Gadolinium is a heavy metal. And whenever you put a heavy metal in the body, it's going to be stored. And it's going to be stored at the expense of something else, something you need. And it's going to cause damage, organ damage to the kidneys, to the brain, to the bones, to the places where it's stored. So gadolinium is a real problem, and we cannot expose healthy women, because that's what the screening population is, right? That's my biggest objection to mammogram, is that we're taking healthy women and radiating them. And for MR, if you're using MR for screening, you're taking healthy women and you're exposing them to gadolinium every year, heavy metal. It's not the right thing to do. So MR is not the solution. And I'm very excited about technology that is coming out of the United States. It's called QT imaging. It uses sound waves transmitted through a water bath that creates a 3-dimensional image of the breast with 40 times the resolution of MRI, all without pain, compression, or radiation. There are only a few centers offering it right now. I will be opening up a center in the suburbs of Philadelphia in July or August of 2024. And I hope to open them all across the United States. And, God willing, someone will take on this charge in other areas of the world. I'm only one person. I can only do so much, although I do dream very big, so And, I aspire to open somewhere between 50 to 100 of these. And this is without question going to be the focus of the next 10 years of my life. And I know everyone wants it tomorrow, and I'm doing the very best I can. But this will forever change how we screen for breast cancer. And the reason is not because of the high resolution images, because although that alone would be enough, this is the only functional imaging available. In that, you can bring someone in and screen them, find a lesion, and bring them back in 60 days, re-image them, and measure a doubling time. And we know that cancers have a doubling time of less than 100 days, and things that are not cancer or not meaningful have a greater doubling time. So this allows us to say, You do not have a lesion that needs intervention. Come back in a year. This avoids the unnecessary biopsies, of which, of all of the biopsies, the breast biopsies that we do every year, 75% are benign disease. 75% of biopsies are done unnecessarily. And yet, once you ring that bell for a woman, it never gets unrung. She thinks she's high risk, right? She goes into a different category. She has to wear this sign. And I'm trying to avoid that. So we can avoid so many unnecessary biopsies, and we avoid overdiagnosis and overtreatment. And we're going to save hundreds of thousands, if not millions of lives this way. Will it eliminate breast cancer? No, of course not. And do we need to work really hard to make sure that people are practicing all the things that we know prevent breast cancer? Yes, 100%. We need to still be loud voices out there. We need to still be out there as shining lights, helping to guide people, for sure. But we can change this very broken system, and we can change it now.
Oh, that's wonderful. So the QT imaging will prevent unnecessary biopsies. So there still will be biopsies done, but not, as you mentioned, like 75% are
Yeah,
benign. So
but
hopefully,
we're
yeah,
gonna biopsy the things that need biopsy rather than biopsying everything.
yeah, makes sense. All right. Well, before we wrap up, we have to talk about healing. So, what are some of the things you recommend when it comes to healing? Obviously, addressing the cause of the problem that
Yeah,
we discussed earlier, but if
yeah,
you could, I guess, kind of summarize.
of course. So, there are pillars that you want everyone to put in place, right? Like how everyone got here is going to be different, and everyone's going to need to address their own stuff. If it's trauma, if you have a history of root canals and you have chronic infections in your mouth, or receding gums, or metal amalgams, or maybe you have parasite infections, or maybe you have food sensitivity, or whatever got you to this space is going to be your story. However, we all need to eat in a way that nourishes us. And for everyone, that's going to be a little different, because the diet that's right for me is not going to be the diet that's right for you, and vice versa. But I think what all of us can agree, all of us in this wellness space can agree, that processed foods are not good for anyone. They're simply not good for anyone. And I don't care if you have disease, if you don't have disease, if you're healthy, if you're not healthy. Processed foods are not good for anyone, and they are having a negative, detrimental effect on your health. So if it has one ingredient, came from nature, and a 3-year-old can tell you where it came from, it's probably safe to eat. And otherwise, leave it. I also believe that we should all be eating a low glycemic diet. And what that means is minimal to no grains. Grains are the seeds of grass. They are meant to be consumed by ruminators. Ruminators have a very long, redundant gastrointestinal tract, as in comparison, we have a relatively short gastrointestinal tract. If we never ate another grain again, we would suffer no nutritional deficiency. And I really don't believe in putting things in your diet without benefit. Now, I get a lot of pushback about my no grain diet. So you can take it for what it's worth. You can think I'm a quack. You can think I'm crazy. You can think I'm whatever you think I am. Where am I getting my fiber? And on and on and on. It's okay. I'm just telling you what I believe. I believe that certainly if you're actively cancering, you should be on a whole food, plant-based, grain-free, low glycemic diet. And if you're not actively cancering, it shouldn't look much different than that. Like, we should spend most of our time in a place that really nourishes us, a whole food place that nourishes us. At the same time, I think that there's a time to eat and a time to fast. And I think that there is a fasting practice for everyone. I think there is very good reason why fasting is built into almost every religion there is. I think that it changes. I think that there are times of the year that you're going to fast in one way and times of the year that you're going to fast in another. We're all tied to circadian rhythm. And so that is another element that should be incorporated because fasting is truly the quickest way to healing. And then we need to move our bodies or we're going to lose our bodies. And what movement looks like changes. Lots of people do really well on pure cardiovascular exercise when they're in their teens and 20s and maybe even 30s. But as you approach your 40s and 50s, you really need to start thinking about muscle mass and maintaining muscle mass and that kind of thing. And that means that you have to lift heavy things. And as you get into your 50s and 60s, you also have to maintain flexibility and balance because that's what connects the mind and the body. So how you exercise matters and it changes. And so making sure that you're moving your body every single day in a way that benefits you. Over exercise is bad. Under exercise is bad. We got to get this right. Goldilocks. Goldilocks. We got to get this right. We have to figure out a way to healthfully manage stress. Because the stress is always going to be there. We're not getting rid of it. It's going to be ever present. And it's not that the stress that matters. It's the effect that we all allow the stress to have on us, the impact that we allow the stress to have on us. And everyone is capable of developing a toolbox to be able to deal with the stressors in their lives. And for some people, it's going to be meditation. Some people is journaling. Some people, I have a very good friend, Marcelle Pick. She is a dancer. And that's how she manages the stress in her life. I think having more than one or two things in your toolbox is important, but building your toolbox to be resilient, to allow yourself to be in control of what comes in and what has an effect on you. Is that going to eliminate the stressors of life? No, of course not. There's still going to be deaths. There's still going to be sick people. There are still going to be divorces and new jobs and moves and all the things that we know can have profound effects on our health. But the better we are at dealing with them, the better our health will be as a result of them. We have to prioritize sleep. Sleep is where the healing happens. So if you're not sleeping, you're not healing. So making sure that you're doing the things during the day that set you up for healthy sleep, and then making sleep a priority and protecting that. We talked about the toxins and eliminating as many toxins as you can, especially those xenoestrogens, because they really profoundly negatively affect your health. But also having detoxification practices, making sure that you're sweating, that you're peeing, that you're pooping, that you're consuming filtered water, clean filtered water to help to flush toxins out of your system, getting plenty of fiber in your diet, and bowel regularity is really, really important. And then lastly, living a connected, heart-centered, purpose-driven life. And I think it's important to say that God put us all here with a unique purpose. And my purpose is not yours, and your purpose is not mine. I am never going to be the best version of you, and you are never going to be the best version of me, and we're not supposed to be. We are only ever supposed to be the best version of ourselves. And you don't have to be saving the world. You don't have to be changing the world. That may be my purpose, and that's okay, but it's not yours. Whatever your purpose is, as long as you're living it, that's okay. That's what you're supposed to be doing. And that is where you get that internal joy, that internal reward that leads to health. So putting that picture together for yourself, that's what you can do. And that's where the power lies. And we have to remember to stop giving away our power, because health happens at home. It doesn't happen in a doctor's office or a chemotherapy suite. It doesn't come out of a pharmaceutical container. It doesn't happen in a radiation suite. Health happens at home with all the things that you do to drive your health.
All right. Well, that was amazing. So much good information. Thank you so much for sharing.
My
And can you,
pleasure.
yeah, no, this was great. So before I ask you where people could find more out more about you, yeah, let's yeah, for those who are tuning in, watching your new book,
Yeah.
so
So
definitely,
this is the Smart
mm,
Woman's Guide to Breast Cancer. It's
yep.
available on Amazon, and it really is for any woman, because this is information that you want. It's information that you need, and it's information that you're going to want to share with your mother or your daughter or your best friend or your neighbor. Um, so definitely pick up that book. If you are looking to work with me, my website is called realhealthmd.com, and all of our programs are on the website. If you want to hear more from me, I have a podcast called Keeping Abreast with Dr. Jenn, and we put out new content every week. I have a weekly blog on my website, and you can follow me on all the social channels at Dr. Jenn Simmons, and my Jen has 2 N's.
All right, awesome. So we'll make sure to include all those links in the notes. And again, thank you so much, Dr. Jen. This was a great
My pleasure.
conversation. Yeah, definitely
Thank
enjoyed
you
it.
so much for having me.
Yeah, you are welcome. And thank you. Have a wonderful day.
Bye for now.